I apologize for the technical difficulties. As you all are undoubtedly aware, we got some winter weather in central Arkansas, and I know that a good part of the state has had winter weather recently. Although our campuses are largely shut down, the schools are out, we are fine, but there are pockets of the city without power, and Kristen is one of them. So given that we decided to go ahead and do the webinar since we figured that not everybody is as affected by the winter weather, and we've invited a number of folks on the call, but I did want you to apologize for just the inconvenience of having to sort out the technical issues. But I appreciate folks being on the call. We've got a great lineup today, and we're going to have a really amazing discussion about where we're going to be going with PCMH towards the end of the call. So this is Dennis Quo. I'm the Vice President of the Arkansas AAP chapter. Please mute your phone when you're not speaking so that we don't have any extraneous noise. At the same time, please don't put your phone on hold, because as much as we like your hold music, there's probably a limit what we can tolerate. So we appreciate your cooperation in that. Justin, if you're controlling the slides, let's go on. Okay. So we're going to hear from our SHARE colleagues just about what's going on with SHARE, the update. And then Kristen and Amy are going to talk about some of their findings from attending the National Child Health Policy Conference overview. There's some really exciting things that were discussed there. And I think it's important and good for us to understand where PCMH and our PCMH efforts fit into the context of where healthcare reform is going. And I'm going to close by just telling you some of the things that we at the chapter are thinking about, and we'd like your input and where we want to take our collaborative next. Next slide. Okay. Our support of the Academy is provided by Arkansas Medicaid. Next slide. And let's go past the next couple of slides. Instead of a roll call, we can catch up later. Okay, Justin, Jan, Deborah, go ahead.
My name is Jan Bartlett. I want to thank you all for joining us today to talk about SHARE. We are, in a few minutes, Deborah Lumbus, who's our SHARE onboarding manager, will give you an overview of SHARE and the impressive progress that we've been able to make since OHIT was established by Governor Beebe in 2009. She'll also be giving a demonstration of SHARE and show you some of the types of data that is available to you in the virtual health record. But before we get started, I'd like to introduce Justin Valines to you. Justin works with OHIT as our patient-centered medical home integrator. In that role, he's available to answer any questions you may have about connecting to SHARE as part of your clinic's participation in the Arkansas Medicaid PCMH initiative. Justin, would you like to say a few words?
Thanks, Jan. I appreciate that. I'm really glad that you got everyone that's on the call today. I think, you know, meeting the activity of SHARE, I think it's on everyone's mind. We want to make that very easy and streamless as possible. I just wanted to, at the end, you know, have our contact information. Please don't hesitate to reach out to us here at SHARE if you have any questions, concerns, or issues while you're onboarding and creating everything you need to connect to SHARE. Again, appreciate everyone being on this call, and I will turn this over to Deborah Lumbus. She's our PCMH onboarding.
Thank you, Justin, and thank you, everyone. I'll just reiterate that thank you for taking time out of a very busy and wintry weather type day, so I appreciate it. Since we are somewhat limited on time and I have a lot of material to cover, I may speak a little bit fast and I may talk at a little bit more of a high level to try to get through the entire presentation, but hopefully at the end we'll have time for questions. And please also know that we're always available to talk via phone, or we also come on site to your practices and discuss the details of SHARE. So this is our agenda for the presentation today. And so Justin, if you would advance to the next slide. Thank you. So we're going to talk about what SHARE is today, and it is the State Health Alliance for Records Exchange, and it is our statewide utility where participating healthcare providers can exchange critical patient information at the point of care, regardless of the electronic medical records platform that they use. The Office of Health Information Technology began this concept back in 2009 when they received public funds through the American Recovery and Reinvestment Act. And the purpose of this funding was to improve and preserve health care, advance health information technology, and other health care prevention initiatives. Advance, please. So SHARE provides that technical infrastructure for the hospitals, physicians, labs, and public health to exchange clinical data when and where it's needed. It's available to any healthcare entity that's willing to abide by our requirements and our user fees. SHARE is vendor agnostic, which basically means that we have the ability to integrate with any EMR vendor that can facilitate the exchange of an HL7 message or a continuity of care document. Advance, please. So why is the sharing of patient information so important? Well, beyond the technology, SHARE plays a critical role in all of the Arkansas Health Reform initiatives by providing that holistic patient health data that drives diagnosis and treatment decisions and simplifies the care coordination process as we move from one caregiver to the next. Patients usually visit many different providers, as you all know, and go to many different locations to receive health care. And each of those providers and locations keep their own medical records on their patients, but providers can't readily access those records about their patients at the point of care. Next slide, please. So when we think about the need for SHARE, take a moment to think about all the different healthcare organizations you coordinate with and how frustrating those communications can be. You work with hospitals, labs, pharmacies, specialists, radiology centers, public health registries, Medicaid and other payers. Your experience is probably like the image on the left, where you're reaching out to all your partners individually, maybe even by phone or fax, to share patient health information. It's very time-consuming and fragmented at best to manage all of these communications for each one of your patients, not to mention how inefficient and costly the process is. So SHARE exists to simplify your communication and your care coordination process by connecting you electronically to every organization that participates in SHARE. So it pulls together your patient's health information from many different healthcare entities to give you a more complete view of your patient's overall health. So you only have to make one connection, and SHARE does the rest for you. Next slide. Next slide, please. Thank you. So as we go through this slide, you can see that there are many benefits to participating in SHARE. It allows doctors and other providers to access important medical information about their patients and have a more complete understanding about the care that's been administered to the patient in other care settings. So not only does this improve care coordination, but it also increases that patient satisfaction and patient outcomes. So now when I go to my endocrinologist, he can see all the tests previously performed with my primary care provider, and he may not have to repeat them. So SHARE also creates efficiencies by eliminating multiple interfaces with every healthcare entity you need to exchange data with. So with that one connection to SHARE, you can also send data to the public health registry. Next slide. So what is the value of SHARE? Well, SHARE really seeks to alleviate that provider fatigue for collecting and reporting data for all the various health improvement initiatives. And these initiatives all have common goals of decreasing costs, improving the patient experience of care, and improving health population outcomes, as you all are very familiar with as the triple aim. Next slide. So people ask, what kind of data can be shared? Well, here's the current list. Our technical team has gone to enormous efforts to offer the ability to transfer each of these data types that you see on the screen in compliance with all federal and state privacy and security standards. So SHARE has the highest level of data security and privacy measures you can access.
Okay.
Next slide, please.
Oh, okay. Okay. I'm on a conference call right at the moment. Is she here right now?
If you can, mute your lines, please.
Okay, so currently SHARE offers 3 solutions for exchanging and viewing patient health information. First, we have our secure messaging, which is simply a point-to-point encrypted email exchange that utilizes the direct messaging protocols. And then we have our virtual health record, and you may hear me refer it to VHR. That is our application that allows end users to view patient data in a secure web portal. Then with our full HIE integration, your practice can send and receive patient health data to the HIE in near real time with no disruption to the provider workflow. If your EMR vendor is capable, your patient's health information from other providers of care can be consumed and viewed within your own electronic medical record. Next slide. So many of you listening today may be participating already in the Patient-Centered Medical Home Initiative. In 2014, Arkansas Medicaid implemented a new requirement for patient-centered medical home practices to enroll in SHARE to access inpatient admission, transfer, and discharge information from their affiliated hospitals. So PCMH practices connected to SHARE enjoy all the full benefits of any other provider. That one SHARE connection opens up all of SHARE's value to the practice. Next slide. The challenge today is reducing preventable readmissions and improving that post-discharge care for patients in your medical home. As a participant of SHARE, you can receive automated notifications when your patients present to the ED, they're admitted to or discharged from the hospital. So the anticipated impact of these notifications are more effective discharge planning and follow-up care that results in fewer readmissions, increased patient satisfaction, and ultimately cost savings. So the Patient-Centered Medical Home Care team can only help patients navigate post-discharge care if they know about discharged patients. So SHARE's goal, once again, is to fill this care transition gap and help patients and providers navigate their care. Next slide. Justin, if you want to go ahead to the next one. So we'll talk about who is currently sharing data. I'm just going to keep this very high level because it would be very difficult to talk about all of the participation we have going on today. But 2014 was a very busy year for us at SHARE. We have 17 hospitals that are live and pushing patient information to SHARE, with 8 more in the implementation phase. We currently have 365 practices that are in production or implementing their connection with SHARE. So just a few examples of some of our larger hospital participants are UAMS, Arkansas Children's Hospital, Conway Regional, we have Jefferson Regional down in Pine Bluff, and White River Medical Center, just to name a few. If you're interested in seeing our full list of participants, then please visit our website at sharearkansas.com. and you can see all of that information. We still have a lot of growing to do, and we're very excited about the opportunities in 2015. We hope you're excited about SHARE as well, and we would like for you to persuade your hospital to participate if they aren't already. Next slide. Here's just another view of our progress. Note that in addition to the more than 1 million patient records, we're actively signing up new practices, and we're now live on 3 public health registries. You can utilize SHARE to send your immunizations, electronic lab results, and syndromic surveillance to the Arkansas Department of Health. Next slide. So as a pediatric practice, you're probably most interested in our connection to WebIZ. So SHARE has built an interface with the Arkansas Department of Health that allows practices to send their immunizations directly to the registry. This functionality allows you to enter the immunization one time in your electronic medical record, and SHARE sends it on to WebIZ. The biggest advantage of connecting to the registry through SHARE is that it eliminates your practice from having to maintain multiple data feeds, and it is also much more cost effective. There is no cost to connect to the registries. It's included in our low monthly fee. Next slide. This is our pricing. Many of you, of course, want to know what does it cost to join SHARE. And with the public funding we receive, SHARE has waived the one-time setup fee per practice. So we only assess a monthly fee of $50 or $75. So for $50 per month, you can integrate your electronic medical record to SHARE. You can receive 1 primary clinical user role and unlimited secondary clinical roles for the virtual health record. And also you can receive unlimited access to our secure messaging solution. And then many of you might be wondering, what is a primary clinical role? And that is a role that is assigned to a licensed professional, such as an MD or a nurse practitioner, that need the ability to access patient information in an emergency situation. And this is what we call our break the glass role. So what that means is if a patient has opted not to participate in SHARE, their information cannot be viewed unless a provider has the break the glass role. So if a patient is in a life or death situation, or there's a federal disaster situation such as a hurricane or a tornado, then a provider could break the glass and view that patient's health information. So since this role is heavily audited, if your providers do not require emergency access, they can receive an unlimited secondary clinical role. Now, there are also vendor fees that will be involved with your EMR vendor. And I can tell you that the Office of Health Information Technology recognized early on in this initiative that practices would be burdened by the cost that their vendors charge them for interfaces. So our executive team has worked diligently with the top vendors in the state to negotiate a reduced fee for connecting on your behalf. These negotiations have actually resulted in savings anywhere from $1,500 to $15,000. So if you would like more details about these vendors and their capabilities and pricing, please give us a call, and we're happy to share that information with you. Okay, next slide. And actually, this will just show you a little bit how you can get started. You can go online at sharearkansas.com. You can give us a call at the number listed, or email us also, and we'll be happy to set up a time to talk with you, come to your practice, and give you a more in-depth view of SHARE as well. Now, we had planned to do a live VHR demo. I'm not sure if, Justin, you can share or turn it over to me, and perhaps I can give the demo, or if we want to save that for another time. I'm not sure how that might work.
Yeah, Deborah, let me get a shot at it right now. Like Dr. Kuo told everyone, there was a lot of technical difficulties, so if you just bear with me, I will do that right now.
Deborah, this is Dennis Quo, and thanks so much for your presentation. I think it's a great. I completely agree with giving it a try to get it over to you, because I think that demonstration is valuable. I have one question that I know some of the answer, and I just like folks to kind of hear your thoughts on this. Some of a big part of what will make SHARE extremely useful will be for patients and families to opt, to use, to have their information implemented into SHARE. And I know about Arkansas being, us having an opt-out policy. Can you comment on how well the SHARE is being populated? In other words, patients and families are agreeing to have their information used at the point of contact with a healthcare provider?
Sure. So we are an opt-out state, which basically means that a patient's records are automatically populated in the HIE unless they choose to opt out. And they're presented the opportunity whenever they register at a hospital or at a provider clinic that's participating. They're given information about SHARE at the point of registration, and Jan can speak more to, percentages of opt-out, but I think that there has been great acceptance on the part of the patients and also parents as well for their children. So I think that we are seeing a lot of participation from the patients. And Jan might also speak to a little bit about how there are efforts to educate patients.
Yeah. We have had very good adoption, and when we have been presented with patients who have written to us and for some reason or another, maybe they chose to opt in and then have changed their mind, we have gone in and taken that into consideration and removed their information. Transparency to the patient is very important to us, and we're glad that we've had good adoption, and we're open to any questions that anyone has on that.
Okay. Can everyone see my screen?
I am still seeing the how to get started screen.
Are you? Okay. Let me see. Let's see if this works.
Okay, I see a thing that says Deborah's screen, but it's blank right now.
Okay.
Yep, there it goes. I see 3 people.
Yeah, you just saw my family there. Okay. Okay, now do you see
Beautiful
share?
family.
Thank you. Now does everyone see the SHARE and the clinical documents in VHR?
I'm seeing it.
Okay, perfect. Okay, so I'm going to give everyone, really, I know we're limited on time, and I want to acknowledge that. So I will try to keep this very high level. And then if at any time any of you want to see this more in depth, you can certainly reach out to us, and we'll be happy to do that one-on-one with you. But our VHR is really a solution that aids us in helping our customers meet requirements for PCMH and also for meaningful use. The virtual health record, it provides, again, that single comprehensive view of a patient's health information that's easily accessible with a click of a button. So anyone that needs access, and we're very strict on how we give access and whom we give access to, but we will go through all of the appropriate access processes and work with your practice and give you a username and a password, so that if you're not able to maybe integrate your EMR with SHARE, you also have this virtual health record that allows you to view all of the patient information. So basically what I've already done here for the sake of time is I've logged in with my username and password, and it brings me up to this menu. And I can either choose to go to clinical documents, which this happens to be the inbox where all of your PCMH alert notifications would go, And then the VHR is just that patient record where you can view all of the data. So I'm going to actually go ahead and click on VHR and then go to my patient lookup. And at a minimum, you need the last name of your patient and a date of birth, or you could use your medical record number, whatever you happen to have handy. And then I'm going to do the search for my patient. And we'll give it just a moment. Make sure that didn't, there it goes. Okay, so you'll notice this patient has opted out as indicated by this emergency status. I wanted to show you that because this means that this patient's records are not viewable except by a licensed provider who can break the glass in an emergency situation. So I'm going to select my option and I'm going to accept the terms of agreement and click continue. And also let me just add real quickly as I'm going through this. This is a test system with test data. So just keep that in mind. Not everything may be clinically relevant for this patient, but this is our play environment. So I'm going to do the best that I can with our test environment. So when you search your patient and you go into their record, this is the summary screen that comes up. And you can see we have a test patient here that's 57 years old and, you know, probably suffers from many chronic conditions. And we'll say that today she's come in to see her family doctor with some complaints. So the chart tabs here at the top organize the selected patient information into categories, just as, you know, colored tabs in the paper chart help you more easily find the patient reports and results by department. So here in the summary tab, this brings together key patient information into a single page. And the doctor can view recent lab reports, recent radiology reports. We also have cumulative labs down here at the bottom if they want to see how things are trending over time. But this just gives you the most recent reports on your patient. Now, if I click here on the lab tab, this would actually bring all of the labs that have been performed and reported to the HIE on this patient. And we know that 70% of clinical decision-making is based on or assisted by lab results. So this is very important to providers. Now, as this patient's PCP, I can see here, if you roll your mouse over the icons, this lets me know that this report contains an abnormal value. And down here you can see that the report contains a critical value. So I'm going to want to pay close attention to those lab results. And if I wanted to view it in detail, I just click on the blue link and it opens up the report for me. And here I can see the physician that ordered the test. I can see what test was performed and when and what the value of that result is. Now I'm going to go back here to the cumulative lab tab because I could graph and trend multiple results of the same type. So for example, I could look at all of this patient's renal values, such as the creatinine, on a graph and see at a glance maybe how well or maybe how, you know, poorly the patient's condition might be managed. Then if I click on the radiology tab, again, here are all our radiology reports. I'll open up the chest view. I can review the doctor that ordered it, where it was performed, and the impression of that x-ray. Another tab that I find very informational is this patient info tab. It gives you all your patient's demographic information. It gives you the medical insurance plan information. Again, very important to have that medication allergy information as well. And we could also see a medication history. Currently in this test environment, I don't have any active medications, but if I click on expired medications, I can see those here as well. So it's important to review the list of medications with your patients in order to prevent any interactions. Also, conditions identified for a patient are presented to clinicians at the point of care as quickly and simple problem lists. And this really prevents the need to sift through long lists of diagnoses and procedure codes. So this is important because this patient has multiple chronic conditions, could potentially have a lot of physicians overseeing her care, such as a cardiologist, an endocrinologist, so you would also be able to see all of the treating providers as well. So that really is the high-level overview of our virtual health record. To meet the PCMH requirements, providers or their care managers are required to receive those event notifications of patient admissions, transfers, and discharges. So to better manage that post-discharge care and follow-up, we will actually tie your Medicaid patients to each of your providers, and they can receive an alert when they have presented at the hospital. Now, up here in the right-hand corner, you will see an inbox, and this goes to our clinical documents inbox, and I'm going to click on that. And this is where you would receive your alert. Let me click on just my final reports here. So I can access this inbox, and you might see things that would say admit visit notification or register a patient, discharge in visit, like the one here. So these are the types of notifications that you should receive in your clinical inbox, and you can just click on that notification, get the high-level details of, you know, where the patient was admitted or discharged and when. And then if you needed more detailed information about what transpired with that patient, all you have to do from here is go back to your VHR, and that would pull up all of those lab results, radiology reports, discharge summaries, you know, any transcribed notes from the providers. So this is how you would access your notifications. So with that, that is very quickly the high-level overview of SHARE, but do we have any questions?
Folks, questions for the SHARE team?
Yes, I do have some questions. This is Soma.
Hello.
Go ahead.
Hi. Hello?
Go ahead.
Yes. I have a question on the WebIZ part. Like, I am already signed up to SHARE. I am on the, like, you showed 3 stages, like number 1 is messaging, number 2 when you can see, you know, the admission and discharge. I am on my level 2 right now. I'm working on my level 3 where I can push my information to the SHARE. And we are using right now Amazing Charts. So my question is, with WebIZ, and I can see in my Amazing Chart, it is saying that they are working with the Arkansas WebIZ through SHARE, but I don't know how it is going to work. So do you think you can tell me anything about it?
Yeah, actually, we recently executed an agreement with Amazing Charts, and you know, each vendor is going to be a little bit different, so let's keep that in mind. Some of them will connect to WebIZ directly through SHARE. There are some vendors that are going to connect directly. So if you want it to go through SHARE, you really need to talk with Amazing Charts to make sure that that is in the scope of your contract. And we can certainly talk about that offline, but it clearly would be to a practice's advantage to connect to the public health registry through SHARE, because it only gives you one seed then to manage versus multiple, because there are multiple registries. And as they're all made available through SHARE, we will connect our providers. So that is one of the advantages, that each vendor, each EMR vendor is going to be very different in how they do that. And I know, Soma, that your practice is going to be our pilot practice for Amazing Charts.
Yeah.
So we're very excited about connecting to you and working that connection out. But I think it's too early for me to say, you know, exactly how that will work. But I believe our next steps are to put together that scoping call where you all can share with Amazing Charts exactly what you're looking for with your connection to SHARE.
Right. But how the SHARE is working with WebIZ? Like in the demo, I don't see anything which is saying that WebIZ and SHARE.
Right. It's really invisible to you because we really act like a router to public health. So you're actually going to input it into your electronic medical record where you normally would enter your immunizations for your children. And what through an HL7 message, then it will be passed through SHARE to the public health registry. So you won't. It really is seamless to you, and you won't even notice it.
Right. So before that, I really have to work with my pilot program with my Amazing Charts, right? That we have to fix it before it starts working, right?
And that is correct.
Okay. Because I just signed up and sent my paper back to them, the Amazing Charts, and then I did talk to the WebIZ. His name is Andrew. Andrew Luker. I sent him, you know, what I need to do, because the whole issue is with me being a pediatric office. WebIZ is very important for me, you know. We are double king, you know. We are putting in Amazing Chart, then we are putting in WebIZ, so it is kind of double king in both places. So I'm very, very much interested on that one, you know. It makes our life a little easier on that. So,
absolutely. Absolutely. And let me just remind everyone on the phone that when you are connecting to the Department of Health, even through SHARE, you still have to go through their registration process at the Department of Health. And a lot of you know that as the MERC system. So you still have to go through that process and register, and then they will let you know when they're ready to test. So there is a process that you still have to follow.
Right. So I
ADH
still have to talk to. I still have to talk to ADH Andrew, right? I have to contact him for that.
You know, don't quote me on the names. I have so many names floating around in my head. I might be inaccurate on that, but I can certainly get you that information and forward it to you.
Yeah, I think, you can send it to me, but I think that's the one. So, but you can still send it to me, please.
Okay. All right. I will do that. Thank you.
Any other questions? Okay. Chair Team, thank you very much. I appreciate your time and your presentation. And I think folks have your contact information. If not, we can help connect folks to you all. Okay, Kristen, are you back on the call?
I am. Can you hear me okay?
Yes.
Great.
Okay. And who's got control of the screen now?
I think I do.
Deborah, if you just give it back to the Amy Olin house, then I can transfer it back over. Dr. Kuo, would you like to have the lead?
I guess I'll take the lead. Sure.
Okay, Justin, you should have control.
All right, Dr. Kuo, it's transferred to you.
Okay. It says I have control. Oh, okay. I've got control. Very good. Okay. We're going to spend a few minutes talking a little bit about the 2015 National Child Health Policy Conference. Kristen, are you able to do some discussion based on your findings and your reports from the without the slides?
Well, sure, and actually I can see them right now. I just am sort of wishing right now I had made them larger because, and just bear with me, as Dennis said, my power's out, I'm on my phone, but we're actually a little short on time, so I'm going to run through this double time. But yes, Amy and I attended the 2015 National Health Policy Conference, and some of the takeaways from that were obviously coverage expansion under the ACA and CHIP reauthorization is in question, the landscape of child coverage in 2015 is uncertain. And actually, even though legislatively things are not very clear, we are actually spending more of the GDP on health care right now, and it's really, time to make the most of it. And Arkansas PCMH was recognized for being far ahead of the game. In fact, one entire presentation I went to was basically trying to figure out how can we possibly measure different metrics and find ways to keep patients out of the hospital and or the ER and find ways to save money. And I was thinking, wow, we're already doing this. Children's mental health needs were discussed and the importance of things like the percentage of school-based mental health clinics, children attending schools with social workers, and schools with mobile response teams were stressed. Can I have the next slide?
Yep. Okay, go ahead.
And one of the breakout sessions I attended was an excellent speaker, David Bergman. He's from Stanford, and I was just cracking up because people are there from all over the nation. And of course, what's the first slide that comes up is from our own Dr. Kuo, his study on, basically talking about how children with medical complexity they exact a considerable burden on the families. I think it's 13.5% of families spend 11 hours per week on care coordination. Over half of families experience financial problems. Over half of families have family members stop working to care for the child, and about half need additional income for all of these medical expenses. And the children with medical complexity account for such a large proportion of healthcare costs. 10% of children account for about 64% of expenditures. The top 1% of children account for 20% of expenditures, and that's huge. And Dennis, I don't know if you wanted to add anything to that slide.
Yeah, no, I think that's right. The reason we're talking about children with medical complexity is because that's where the lion's share of cost. And we're talking at the end about bending the cost curve. So in other words, if we want to sustainably keep healthcare, the rate of healthcare costs rising at the rate of inflation, we are going to have to address where the costs are going. In pediatrics, the costs are predominantly in a very small number of children, and so as we address the patient-centered medical home and where the PCMH is going in the future, we need to be thinking more and more about the children who have chronic health care needs, particularly the kids who have complex care needs. Kristen, should we go on?
Sure.
Okay.
I actually can't even see the slide, but the presentation on system and care model innovation was talking about the majority of programs for children with medical complexity are in the hospitals, and the problem is that, it's important for the families to receive care close to home, and it's less expensive for the kids to be cared for in the community, but they don't feel like they have the clinical expertise to care for children with medical complexities. They lack the necessary care, coordination, and mental behavioral health services. And when they do care for these patients, they're not reimbursed a lot of the times. So that's like a roadblock into helping get these children to be cared for within their own community. And Dennis, you can either add on to what I'm saying or you can advance to the next slide.
Yeah, let's go. And I think that's a great summary. So, but I think what we need to do is just talk about kind of your next slide is where is this all going?
Okay. Some of the changes in the future includes dynamic care teams, tailored care coordination, individualized access plans, transformation of community pediatric sites to care for children with medical complexity, and hopefully the future holds sustained and active care through enhanced monitoring and telecommunication, hospital care at home, patient and child self-management, and integration of school and community services. And I can expand on dynamic care teams or tailored care coordination, or we can keep on going because I know Dennis did a lot.
I think for time's sake, let's go on because we can go over that at a future time. If you're okay, shall we go on to the next slide? Should we skip this one and go to the next slide?
Sure, yes, because I'd like to give you the chance to talk about the future of PCMH.
Okay. Folks, we're going where the AAP chapter is going with this is the child health care policy, I think, was an excellent summary of where child health care reform is taking place. And it's worth thinking about where the changes we are making in PCMH fit into all of this. The takeaway message is I did not have the opportunity to attend the conference, but I know a number of folks who presented at the conference. I know David Bergman from Stanford very well, for example. And Arkansas really is ahead of the game as a state in implementing healthcare changes. They're really looking at they're really looking around the country at our system in Arkansas, and that is a huge compliment to the system that our payer colleagues have set up. So the takeaway messages are that children with chronic medical conditions, but particularly medical complexity, have the highest needs and costs. But the payments are really starting to be aligned to support things. Like you'll see some of the terms like care teams, registries, population health and outcomes. There's a lot that's really still in evolution. But thinking about the PCMH in Arkansas, you know, at the end of the day, we are now setting up things like your population registries, your EMR, share, systems are talking to each other, and then the metrics end after 24 months. And the question we asked ourselves as an executive committee, your executive committee, including Dr. Davis, Dr. Schluterman, Dr. Ochoa, myself, Dr. Rogers, we have been talking about where we want to go with PCMH to go beyond the requirements, to go beyond the care coordination and practice infrastructure. When it's all said and done, and the metrics are, the immediate two-year metrics are done, what are we left with and where do we go from here? But the PCMH framework, which again is being spread all over the country, is an incredible opportunity. Now that we have transformed so many of our practices, we really need to be looking at additional opportunities for improving care for our kids, but also helping to bend the cost curve. So I'm going to pose a couple of questions, and we're going to start approaching practices individually about how you want to see our chapter go with future projects. And I'm going to give a couple of ideas here. So one goal is, what are the goals for your practice that you can use PCMH to address? Like, do you want to concentrate on certain populations? Do you want to address your clinic flow? Do you want to address the issue of after hours? And then the second is, where do you see your role within the care system? And what I mean by that is, with you as a primary care practice, you've got a child with medical complexity, a child with multiple care needs. Think about what you want to do within PCMH that is going to help the child and family's health care and healthcare system. As Kristen has said, the highest cost children, a lot of the care tends to be at Children's Hospital, but there is a tremendous role for primary care practices to maintain in the care of that child, particularly in a state that is very rural like ours, where a a lot of children who come to Little Rock actually reside in communities that are 50 to 250 miles away. And I can tell you that around the country, they are setting up healthcare systems that have a lot to do with how close the child lives to the hospital, and that is not something that's going to work for Arkansas because of the distance that many of our children have to travel to come to Little Rock. In the American Academy of Pediatrics Arkansas chapter, we have done a number of QI initiatives. Many of you participated in the Asthma Project. The Chapter Quality Network from the AAP had put together this Asthma Project, which, again, many of you participated in. But if you participated in that project, you'll remember that we had planned care process. So we had a plan of care that said that every child with asthma has to go through these steps of care in order to make sure that they consistently get their asthma care plans, their proper medications, and their education. We kept the registry of patients with asthma. We used data to help us improve and meet the metrics that we set for ourselves, and we used the model for improvement, which says that to make changes, we needed to know where we are, where we're going, and what are we going to do to make changes. So these are all things that we're doing within the PCMH, and if we're not doing it actively, we certainly should be moving towards PCMH, but the PCMH offers us the opportunity and staffing and payments to be able to use data and have care registries. The state chapter under the AAP Chapter Quality Network provides support and leadership, and there was actually another quality improvement project that is coming out from the AAP that is centered around ADHD. But where we want to go with this project is that we want to have folks discuss, and in the next couple of months, we want to develop a new initiative that supports the PCMH implementation, but also demonstrates outcomes for a chronic condition of our choosing. So we can continue to work with asthma, or we can, if we decide as a group that we want to work with ADHD or obesity. The reason that we are proposing that we do this as a chapter is that we want to really get on the ground and use the infrastructure that we're implementing with PCMH and really work on the ground to have immediate and improved outcomes for our children with chronic health care conditions. We can go back and work at asthma. That is always a worthy project, and we can really spread it to our populations. We can work in ADHD. We can work in obesity. That's come up from a number of folks. But I'm interested in hearing your discussion and thoughts, and we'd love for you to be able to take it to your providers and staff and let us know what you all are thinking about. So short-term outcomes that, running a new project is that we want folks to keep a registry of patients, implement quality improvement processes, but the target is that if we're looking at short-term outcomes of reducing emergency room and inpatient visits, that's where we can have the most impact for healthcare quality. Because it's 110, we'll wrap it up and say that we're going to start coming to folks and discuss this individually. We want to know what your goals are. What are your goals for PCMH? Now that we have PCMH really up and running, how do we want to use that to really target the needs in your practice, but really target health care for children within your practice? We can consider doing that for our next in-person learning collaborative meeting. And that's where we're going to take the practice transformation and the care coordination that we've all developed and really apply it to child health. And that's really going to make a difference in improving health and outcomes for our children in Arkansas. So it's 1:10. I'd like to wrap it up, and we'll come back to folks individually. I'm interested in reactions, questions, concerns about PCMH. We didn't put slides together for the PCMH metrics, but the one thing that I did want to let folks know is that if you haven't received that email already, the HPVs are live, and we're still trying to clarify a few of the details, but the HPV, the 2015 list is live, and it looks like the 2014 list carried over, but the opportunity to update your HPV list for 2015 is now open in AHEN. So if you haven't had a chance to look at it, I'd invite you to go ahead and take a look at it. If you run into any issues, have questions, let us know, and we will certainly funnel the questions over to the appropriate folks at Medicaid and get back to you. Chris and Amy, are there any questions, or are there anything else, or if there's anyone else in the executive committee, please feel free to chime in.
Yes, I have a question again. So this is Soma.
Yes.
I was looking on the portal, the AN portal on PCMH for my high-risk patients, and I really do not know how to pick that, you know. I do not know which one should I go to look it up, and, you know, I really, if there is any instruction you can, you know, put it in, you know, we know it is live, it is there, but I just don't know how to go step by step. So if you can put some kind of instruction, that will be great.
Okay. Can we follow up with you on that? Do you have, Kristen, are you able to follow up after the phone call? Because we can certainly walk you through how to do that.
Yes, please.
Having done that.
Yes, please.
Okay.
Definitely.
Yeah, the short answer is that what I have done personally is that you can download the file. I actually found, depending on how many patients you have, you may find it easier to download it into the Excel spreadsheet, and that is an option on there. And then after that, it's a matter of knowing what is in the columns. You know, they've got risk scores that you can stratify by. If they were indicated as a high priority beneficiary in previous years, that should be indicated as well. And what you can do is, what you do after that is you review your patients. If you decide, if you do nothing, then the top 10% based on risk score will be chosen for you. Now,
yeah, that happened last year.
Right.
I missed the deadline, but they were not really whatever they picked. I really don't think they were really high-risk patients. I would rather pick myself so we can say they are exactly high-risk. And I have to pick only 10%, right? Our
correct.
patient
Yes,
level.
I agree. I think, yeah, and the issue of the risk scores, I agree that I think the risk scoring is less than perfect, and it's dependent on the claims that they have. But
exactly,
you know,
that's what I thought. Yes.
And I agree, and so I certainly encourage you to review your own patients and select. So you can go in and unselect those children that you don't feel are necessary, and select kids that you think are appropriate to be on an HPB list. I find it easier to personally. I find it easier to download the file into an Excel spreadsheet so you can see it all at once instead of having to go through the system. Does anyone else have any other tips or questions about that? Okay. Can we follow up with you about that then?
Yes, please do that. Please do
Okay.
that. I'm really waiting for that. Okay,
Great.
thanks.
Okay.
Do you need any information of us, or you will know who I am from the? You will have my email ID in the webinar list, so you can email me.
Okay, Kristen, do you have it, or you can follow up?
I do not have your email address on webinar on WebEx, but you can email me at Crispin_Pfeiffer@yahoo.com, and I will get back to you about this.
Oh, can I in a chat box my email ID? You can get it.
Sure, you can do that, and also on all of the emails that I send out to join these webinars, you can see all of my contact information at the bottom.
Oh yeah, Kristen, I have your email. I will send you email. How about that?
Okay.
Great.
Okay,
Thank you.
Thank you. Bye.
Okay. Folks, it is past time. We'll follow up with you individually. Thank you again. Please stay warm and safe in this nutty wintry weather we've been having throughout the state. And we'll hear from you next time. Thank you.